Good evening, doctors. Thank you all so much for joining this panel discussion. My name is Rebu Ninan. I'll be a moderator today, and I would like to start the session off by introducing the members of this distinguished panel. I will start with Dr. Biju IK. Doctor, may I request you to please introduce yourself?
Hi, I'm Dr. Biju 𝐿𝐄𝐄𝐓. I'm working as a senior consultant gastroenterologist and head of the department in southern state Kerala, that is in Baby Memorial Hospital, Calicut. Okay. I did my MBBS and MD from Calicut Medical College and DM from Mumbai University. Okay. We're basically interested in general gastroenterology, therapeutic endoscopy, and hepatology also. That's all. Very good evening.
Excellent, Dr. Biju. Thank you so much. I will next request Dr. Raja Prasad to kindly introduce himself.
Hi, I'm Dr. Raja Prasad, surgical gastroenterologist from Hyderabad. I work for Omni Hospitals, Kokatpalli. I've done my medicine and surgical specialty from St. John's Medical College, Bangalore. And following that, I did my fellowship in surgical gastroenterology from Nizam Institute of Medical Sciences. Right now, I'm working as a consultant surgical gastroenterologist in Omni Hospitals, Kokatpalli. I have 15 years of experience, and I'm mainly into advanced laparoscopic procedures, bariatric, and hepatobiliary pancreatic surgeries. Thank you.
Excellent. Thank you so much, Dr. Raja Prasad. Thank you so much for joining us. I request Dr. Kaushal to please introduce yourself.
Hi, good evening. I'm Dr. Kaushal Madan. I'm a Principal Director and Head of Clinical Hepatology at Max Hospital, Saket, New Delhi. And my main focus here, although I'm trained as a gastroenterology, my focus area of clinical practice and research involves and revolves around hepatology over the last 18 to 20 years. That's it. Thank you.
Good to meet you, Dr. Kaushal. Thank you so much for joining us on this extremely busy Monday evening. Next, I would request Dr. Madhu Sasidharan to kindly introduce himself.
Hello, I am Dr. Madhu. I am working in KIMS Hospital, Trivandrum. I am working here since last 10 years, and we have active transplant program since last 7 years. I am more into hepatology and a little bit of therapeutic endoscopy. Thank you.
Welcome to the meeting, Dr. Madhu. Good to meet you.
Thank you.
So my name is Rebu and I'm going to be the moderator for this panel discussion on Nash today. I work in a business intelligence company called Global Data, which is based in the UK. We support about 36 different industries, including banking, retail, insurance, automotive, and pharmaceutical, with strategy consulting and business intelligence services. We have a lot of services in the pharmaceutical biotech space. And kicking this session off today, we're going to start straight away with the discussion on non-alcoholic steatohepatitis and the management of the same in India. So what I've thought is I just put the slides in the background. These are not necessarily anything more than to have a conversation starter. These are the topics that we will be covering broadly. We'll be talking about the disease, the diagnosis and staging, the unmet needs, epidemiology in India, the patient journey, the treatment algorithm, some of the developments in terms of biomarkers and the drug development pipeline. So while this is playing in the background, I would just like to have the group think about Nash as a disease and the challenges it might have in terms of diagnosis and presentation in India. Dr. Kaushal?
Yeah, Dr. Rebu.
Yeah. Could you please talk to us about the disease burden of Nash in India in terms of the epidemiology, the prevalence and incidence of Nash in India?
Right. So I think we all know that normally fatty liver is caused by alcohol. That was the general version earlier. But over the last 2 decades, people have realized that the metabolic syndrome, obesity, diabetes These are the patients who also have fatty liver disease, and in them it is called non-alcoholic fatty liver disease. And and in this last decade, people have realized that this possibly is the most common cause of the disease, which is contributing to the maximum burden of chronic liver diseases in not only in our country but around the world. So if you see the world data, about 1/4 of the population has non-alcoholic fatty liver disease. Coming to India, there have been multiple studies done both in rural population as well as urban population. The studies done in rural population, the oft-quoted study from West Bengal suggests that the prevalence or the burden, if you want to call it, is about 8% of the general population in that localized rural population. Whereas if you go to the cities and urban areas, the prevalence may be as high as 25%. And there was a study done in blood donors from Chandigarh, where it was found to be as high as 50%, suggesting that as the affluence increases, the patients become more and more obese, they have more and more metabolic syndrome and diabetes, the prevalence increases. And possibly now, if you look, the most common cause in the society of deranged liver enzymes and consultation to a hepatologist is non-alcoholic fatty liver disease.
Absolutely. Thank you, Dr. Kaushal. Dr. Raja Prasad, could you please tell us your thoughts about the disease burden, how it might change in the Indian scenario between the rural and the urban setting?
Yes, sir. Good evening. Like Dr. Kaushal has said, the urban population, because of the lifestyle changes and increase in obesity, the incidence is much more higher in the rural, urban population as compared to the rural setup. Like you said, the percentage of Nash or NAFLD, that's non-alcoholic fatty liver disease, around 8% in the rural as compared to around 30 to 40% in the urban population. And compared to the Western population, Indian population, there's something called as Asian paradox, where we even find people who don't have a very high BMI or diabetes still having a lot of fatty liver disease. And this is something to worry about, and which is generally seen in the Asians. And in the rural population, like I said, 8%. And the other thing is the increase in diabetes and obesity in India. That actually can, in the near future, we may be seeing more patients with NAFLD and Nash in the Indian population because of change in lifestyle, increase in the diabetes. We have around 10% of diabetics in India, and obesity. So, and rural areas, the incidence is much less. Probably because of less investigations as compared to the urban population. But I think obesity is not the only reason, and even non-obese, diabetes, insulin resistance, all of these also can be a very important factors for patients developing NASH and NAFLDs.
Thank you so much, Dr. Raja Prasad. My next question is to Dr. Biju. Could you please help me understand what might be the typical patient journey for a patient who has NASH from the time that he suspects a problem till the time he meets a gastroenterologist and a treatment is recommended? Could you just help me understand the patient journey?
Now, this as from my co-panelists, it has been very clear that fatty non-alcoholic steatohepatitis is very common. Around 1 in 4 of persons is having around non-alcoholic fatty liver disease. But even though the prevalence is so high, we are seeing only the tip of iceberg, because majority of the patients are not having any symptoms. So how will we see these patients? Because most of the patients are not having any symptoms. So occasionally they come for a medical health checkup, and you see some fatty liver and abnormal elevated transaminases. Sometimes they may get an ultrasound or a blood test during a preoperative evaluation or some other executive checkup like that. Very rarely they may have symptoms like right upper quadrant pain or fatty or malaise or fatigue, like that sort of symptoms. So how will we diagnose fatty liver? How can we increase the awareness among the peoples? Without increasing the awareness among the people, we cannot diagnose this fatty liver disease. So we have to screen, we have to target on certain type of populations, especially people with diabetes, people with central obesity, those having very, especially the belly type of fat distribution, which is more common in our parts. Like if the waist circumference more than 90 for the male and more than 80 for the female, that is very significant. And patients with diabetes, if you can see in our paper, in our diabetic population, around 2/3, more than around 70% of people are having diabetes mellitus. And people with dyslipidemia and other metabolic syndromes like hypertension, hyperuricemia, etc. And people with endocrinopathy, that is diabetes mellitus, polycystic ovarian syndrome people, patients with the menstrual irregularities, obesity, insulin resistance, these sort of people also will have non-alcoholic steatohepatitis. And we have to target on people who is having very high, very sedentary habits. These sort of people will be having, and patients with the OSA people, and patients, that is a patient with obstructive sleep apnea. And those sort of people having a lot of medication intake, like corticosteroids, and those taking anti-epileptic, antidepressants, and chemotherapeutic agents, and certain medications like methotrexate, etc. Those sort of people, we have to target and screen those sort of people to whether there is an incidence of the fatty liver or non-alcoholic steatohepatitis is high. And people with diabetes mellitus and people who had undergone bariatric surgery also, we have to screen and chase those people for fatty liver and non-alcoholic steatohepatitis. Unless we target these sort of peoples, we cannot do a routine screening of the general populations to diagnose fatty liver disease. We have to target on high-risk peoples, which I have mentioned. I think that will be the way to diagnose, and patient motivation for the recognizing this pandemic that's called silent pandemic, Nash.
Doctor, that's a very important point you bring up, especially about the awareness from the patient perspective. What do you think about the awareness among general physicians who might be the first point of contact? Because ultimately they might also need to be more aware so that the referrals can come to a specialty center.
Nowadays, the radiologists are more tuned for diagnosing and picking up fatty liver, and general physicians are also tuned for diagnosing and picking up fatty liver. But the problem is, you have to see which all patients are likely to progress for non-alcoholic steatohepatitis and progress for chronic liver disease. And it is not that always it will be a NASH. We have to exclude other situations likely to produce similar presentations, like chronic hepatitis C, chronic hepatitis B, autoimmune hepatitis, metabolic liver diseases, etc. has to be screened. For that, actually, the physician has to see these patients, and he may have to direct these patients to a hepatology center or hepatologist or a gastroenterologist for further workup and to exact prognostication and exact diagnosis of this clinical scenario.
Excellent. Thank you so much, Dr. Biju. Just a quick question back again to Dr. Kaushal about your commentary on the availability of specialty gastroenterology centers by type of cities, metro, tier 1, tier 2, and then rural areas. Do you think that is currently affecting the access to treatment, Dr. Kaushal? I think we may. Okay, yeah. Dr. Kaushal is back. Hello. Dr. Kaushal, are you able to hear me?
Yeah.
Hello.
Hello.
Hello, Dr. Kaushal. Please go on.
Can you hear me?
Yes, I can. Please go on. Hello. I think we've had a
Can you repeat the
technical issue.
question,
So,
sir?
yeah, sure. The question I was asking is about the Dr. Kaushal's opinion on the access to treatment based on the presence of specialty gastroenterology treatment centers in metros, tier 1, tier 2, and then ultimately in rural areas. Is that affecting access to treatment? I think we may have lost Dr. Kaushal, so I'll skip that question. My next question will be to Dr. Madhu. Good evening, Dr. Madhu.
Hello.
My question to you is really about the mortality and morbidity associated with NASH at its later stages. Could you please help us understand the seriousness of this condition?
So in my clinical practice, actually about 40% of CLD patients are NASH-related cirrhosis. And on checking our transplant list also, we find that around 40 to 50% of patients are having probably NASH-related cirrhosis and its complications leading to transplant. So in our OP, we see at least 1 or 2 cases every week who have NASH-related cirrhosis with HCC. So all these patients are probably complicated NASH patients. And as you know, Kerala is a highly endemic area for fatty liver. We have at least 40 to 50% of patients having abnormal LFT on routine checkup. So all these patients need chronic follow-up and regular follow-up so that we can pick up these patients and properly treat them and at least avoid the complications related to the fatty liver.
Doctor, Dr. Madhu, can you please comment on the stage of disease at presentation, how that affects the treatment and the outcome?
Majority of these patients, they come only with fatty hepatitis. Very minority of patients come with cirrhotic stages, where you detect the patient to have a cirrhosis when they come with an index bleed or with a hepatocellular carcinoma.
Okay, excellent. Dr. Kaushal, thanks for joining again. My question, Dr. Kaushal, to you earlier at this point was about the access to specialty gastro centers across our country. Your thoughts on the access in rural versus metro cities?
I think now, I think there are a lot of courses in DM as well as DNB gastroenterology, and a lot of young gastroenterologists and budding hepatologists are getting trained and providing their services even in the periphery. So I think in the current situation, there are a significant number of gastroenterology or hepatology referral centers, at least at the district levels. I'm not sure whether in extreme periphery gastroenterologists are available or not. So that's an issue. But the kind of care, and the kind of awareness you want there to be among the physicians, that can easily be imparted by these gastroenterologists to the practicing general physicians who are there in the periphery, who can give at least the primary care and refer the patients who really need care at the tertiary level or secondary level to a gastroenterologist or a hepatologist. So I think gastroenterologists have been able to, spread their wings and themselves and their knowledge across the board.
Excellent. So there is now wider access to treatment than there was perhaps a few decades ago.
Yeah, definitely.
Yes, definitely.
Excellent. Excellent. So my next question is to Dr. Raja Prasad. This is really going to talk about the specific diagnosis of NASH and the methods for diagnosis. Doctor, can you please tell us about the methods of diagnosis in NASH?
Though I may not be the best person in this group to answer this with so many hepatologists, but the basic investigation which is done, which is ultrasound and a liver function test. Like what Dr. Madhu and Dr. Biju has said, most of these patients may not have any altered liver function test, but they may show early fatty liver, grade 1 or grade 2 fatty livers. And in these patients, they have to be assessed for the risk factors, and further investigations will be based upon their risk factors, like either diabetes and or obesity or the lifestyle habits. So now, I mean, what we have seen in most of our places, I mean, the FibroScan or the elasticity scan has been done quite regularly in most of the places. And I think that is where most of them are picking up early fibrosis and steatohepatitis in patients, especially the elasticity test for the livers. So I think, I mean, since I live in Hyderabad and it's a metropolitan city, there is access to FibroScan for most of the patients, and every high-risk patients, they have to get an elasticity scan done also to assess for the fibrosis or advancement to cirrhosis, along with a complete hepatology, I mean, gastroenterology workup like an endoscopy to look for any signs of cirrhosis and portal hypertension. But the basic investigations are ultrasound and liver function tests, which will give us a hint towards whether the patient is a high-risk category or in a low-risk category.
Thank you, Dr.
Thank you.
Raja Prasad. Can you also comment on the role of biopsy, liver biopsy, in the confirmation of NASH? Is it a required step, or is it something that's in the past now?
Liver biopsy is actually a definitive diagnostic tool. So whenever we have a doubt on the ultrasound or the elasticity or the FibroScan, a liver biopsy is the one which will actually give a clinching diagnosis about the level of steatohepatitis or the fibrosis or the level of cirrhosis. So if a biopsy can be done, that will be a clinching diagnosis where you can get a definitive diagnosis about the patient's disease. But biopsies are not very commonly done, and they're done in very few centers which have a very good gastroenterology setup, because it needs to be done under guidance and they need good follow-up. But like you said, biopsy is the best diagnostic modality to look at the liver disease and the progress of the liver disease.
Thank you so much, Dr. Raja Prasad. The reason I asked this question is because when we were talking to KOLs in the US regarding the great unmet needs in the space of NASH treatment, the number one area that they spoke about is the invasive nature of the confirmatory tests. So we were also thinking whether that is something that needs to change for more access to treatment. That's number one. Now, my next set of sorry, yes, Dr. Kaushal.
Can I come in? So I think the point was definitely made by Dr. Raju. If you ask me, over last 20 years, how many cases would I have done for confirming a case of non-alcoholic fatty liver disease? I can count on fingers. Okay. I think even now, if you we are in the process of formulating guidelines for our National Hepatology Society in NASL. There also, I think the consensus was that apart from clinical trials or apart from differentiating competing etiologies, for example, if you have a doubt between a patient having non-alcoholic fatty liver disease or another etiology, apart from these two indications, I think biopsy is rarely required now for making a positive diagnosis of non-alcoholic fatty liver disease. Yes, when you want to confirm whether the patient has an advanced disease or not, whenever in doubt, which has not been cleared by a non-invasive investigation, that also can be a third indication for resorting to a biopsy. So biopsy these days is very, very rare. And in the current practice, 99% of the time, we will not advise a biopsy for a NAFLD patient.
Thank you, doctor. That was a very important point, because I think very different from what we understood when we spoke to doctors in the West was that they still consider that to be widely used. My next set of questions is regarding the management and treatment of NASH. Dr. Biju, could you please help us understand the treatment guidelines that your hospital and yourself follow for the management of NASH? Is it global guidelines? Is it Indian guidelines? How do you determine the treatment process?
Actually, we cannot rely on guidelines. All the treatment has to be individualized for this particular problem. Actually, the management starts from seeing the patient itself. We have to see the patients and do a complete general examination and look at his BMI status and look for any features of any obesity, like we have to see his waist circumference, and we have to see whether he has got any buffalo hump, and any features of chronic liver disease like stigmata of chronic liver disease has to be looked for. And after diagnosing a clinical diagnosis of non-alcoholic steatohepatitis with the available investigations like blood liver function test, ultrasound, and fibroscan if available. And as already mentioned, liver biopsy is rarely done, only for drug trials or like that. But none of the available non-invasive investigations can quantify the fat. So still, without an invasive test, we don't know how much is the fat burden in the liver. So as far as the management is concerned, we have to go for a lifestyle. First, we have to go for lifestyle modifications, then pharmacological treatment, of which the lifestyle modification is very important, of which the diet and exercise comes the first. Now, how to get, and diet and exercise is also very important, and we have to exclude, if suppose he may be predominantly having obesity and fatty liver disease, and on top of it he may be taking a binge of alcohol, so that is not at all allowed. If he's already having a damaged liver due to the non-alcoholic state of it, so he cannot damage his liver further with a little bit of alcohol. So he has to stop, absolute stoppage of alcohol if he is taking alcohol. Then we have to go for any preventable causes. Suppose he may be having non-alcoholic fatty liver disease, he should not get an hepatitis B infection or a hepatitis A infection. So if there is any only preventable hepatitis are hepatitis B and A. So he has to be vaccinated against hepatitis B and hepatitis A. And generally, we have to see, we know that in the fatty liver disease, the liver is not the killing factor. Most important cause of mortality is the cardiovascular causes. So we have to we have to see his general other systems, and we have to see his cardiovascular status, and a proper cardiac evaluation has to be done, and all the reversible factors and all the modifiable cardiac factors has to be modified, and his diabetic status, dyslipidemia, etc. has to be controlled adequately. And so in the lifestyle changes also, we have to ask him for regular exercise, and in the diet, what all things can be advised. Actually, we have to cut down his calorie intake as much as possible. Ideally, we have to cut down a calorie deficit of 500, minimum 500 has to be made, so that we can expect a weight loss. And the fat intake in the diet has to be reduced, and we have to increase the fiber content in the diet. And in the carbohydrate, we can advise him for more or refined type of carbohydrate, non-refined type of carbohydrate. Refined type of carbohydrate, example white rice, etc., has to be curtailed as much as possible. We can go for unrefined type of carbohydrate, and he has to be advised to introduce more vegetables and salads. Nowadays, the increase in the fruits content is a fashion but the fruits increasing the fructose content can adversely affect the liver. So actually, the fruits has to be in the moderate amount, and in the fruits, better to avoid fruit juice. Better to sort for cut fruits, because if you are doing for fruit juice, the calorie content again increases, because we add lot of refined carbohydrates to increase the taste from the fruit juice. And black coffee, even though controversial, is found to be some useful in the non-alcoholic fatty liver disease. And among the fat, we can advise more polyunsaturated fats, like which is available in the fish, like small fishes, the polyunsaturated fats, and some eggs, and flax seed, some seed oils also has got a lot of polyunsaturated fat. So in the diet, we can go for these sort of modifications. And in the exercise part, we have to be very careful. And it is not that initiating the exercise, it's not only the initiating the exercise, but the maintaining the exercise is also, in that we have to see all his psychosocial aspects has to be considered. Why he is not motivated for this sort of weight reduction? He may be depressed. In that case, we may have to address his depression. He may be having other socials. He may be alone in the house. He may not be having any other social supports. So those type of issues also has to be addressed. Then if he is ready to go for exercise, what all things he has, ideally he has to go for walking or any other exercise minimum of 45 minutes per day and at least 5 days a week. And the goal of the exercise is to maintain at least 60% of the target heart rate has to be attained. So the walking, jogging or rhythmic aerobic exercise, whatever is possible, can be advised. Now, suppose we can achieve weight loss by all these modalities like exercise, diet and all. If we are able to maintain a weight reduction of about more than 10% in about 6 months, more than 10% weight reduction in 6 months can have significant improvement in the Nash status. That is, it is found that it is around more than 45% of patients having a significant improvement in the liver enzyme status and in the imaging status, and also in the fibrosing status also has, even the fibrosis, 45% of the patients fibrosis also found to be some regression if we have got around 10% weight loss in the over the 6 months. These are the main important lifestyle measures which is advocated in Nash treatment. Now, whether to go ahead with the medicines also, we know that there are many current available medicines like vitamin E, pioglitazone, and this UDCA, etc. These are also found to be having useful in terms of reduction in the transaminases levels, and some drugs in the randomized trials, and found that it is found to be reduction in the fibrosis status also. So combining of drugs along with the lifestyle medication can produce significant reduction in the transaminases and fibrosis, but this is going to be a lifelong process. So the patient has to be extremely motivated in terms of initiating and maintaining, and all other social supportive factors also has to be considered in advising these treatments.
Thank you so much, Dr. Biju. In fact, I was just reflecting on your point about lifestyle and pharmacological interventions, and I was wondering whether the newer type of jobs being more sedentary has contributed to increased incidence of this disease in a younger population than it was seen in the past.
Exactly. This is because of the lack of exercise and more time spending in the computers and offices. In the younger age, the incidence of Nash is increased. Actually, what we are seeing in my clinical practice also, we see lot of people in the computer profession and other people between 20 and 40 coming with the central obesity, fatty liver, and non-alcoholic steatohepatitis. Along with that, some alcohol also may be contributing. So predominantly, it is a non-alcoholic steatohepatitis. They coming with a lack of exercise, with a lot of stress, work pressures, and shift duty. Most of them will be working in the night also with daytime sleepiness, and they will be having obesity and sleep apnea also will be having. So a lot of people in the young age is having these issues nowadays, and it's very difficult to motivate them for exercise and diet control. So, and they love fast food because they have got easy money in the younger age itself. They are getting a lot of money, and they love fast food, and they love fast food, and they are most of the time they will be seeking or that sort of ready to eat food and ready to cook food, and most of the time they are buying this ready to eat food, and they are depending more on the snacks, not on the regular meals. So they are more depending on the snacks, which is more calorie rich snacks, and that itself is contributing to the Nash in the younger populations.
Thank you, Dr. Biju. My next question is to Dr. Madhu, and this has to be, can you give us a little more elaboration on the pharmacological interventions, the current drugs that you use based on the different patient types that you're seeing with Nash?
The majority of my patients are suffering from metabolic syndrome. So I concentrate more on dealing with the metabolic syndrome of the patient, like control of diabetes, lifestyle modification,
Okay.
and if there is hypothyroidism, you correct the hypothyroidism, dyslipidemia. And after that, very few drugs are actually available. Therapeutic options are very limited in case of NASH at present in India. So we have got only very few drugs which we can use in a NASH patient in India. The usual drugs which we all regularly use is ursodeoxycholic acid, which has been proved to have a beneficial effect with normalizing ALT levels, and vitamin E, which should be used at a dose of 400 milligram daily. And now saroglitazar has been approved by Indian FDA for use in diabetic patient with NASH. So that has also been found to be of quite good use in my NASH patients.
Excellent. Dr. Sasidharan, in fact, I was going to come to that. My question about that was, given the existing treatments, can you tell us what are the factors that you would think about while choosing different pharmacological treatments? You mentioned that metabolic syndrome is the majority of the patients that you manage. But beyond that, are there other factors that you would consider for selecting the drugs, including access to treatment, affordability, and so on?
Yeah, definitely. All these drugs are costly, and you have to factor in the patient's socioeconomic status before you prescribe a drug. And many of these drugs have to be used for long periods of time. So patients are probably exhausted with their financial sources when you have a disease which has got no endpoint of treatment, unless you can reduce the metabolic syndrome predisposing factors.
Doctor, as you also correctly pointed out, as a company, we have been tracking the global drug development pipeline for NASH with a lot of interest for the last few years. And we were also very excited to note that the very first drug in the world approved for NASH was in India, the Zydus' saroglitazar. Can you tell us how that has changed your treatment paradigm for your patients? This question is to Dr. Biju or Dr. Madhu. The availability of saroglitazar, has it significantly changed the way the patients are treated?
Yeah, saroglitazar is probably the first drug to be approved officially, which is found to benefit even in fibrosis patients, NASH-related fibrosis. So I have been trying this drug for past couple of years, maybe. It is beneficial and is probably useful in the clinical.
And accessible also.
Yeah, accessible also.
Excellent. Dr. Biju, your thoughts, please?
Actually, for the last few months only, I have started saroglitazar, and I'm happy with the results. But the problem is how long to continue this patient, how long to continue this treatment. So majority of the patients are now continuing, but most of the time, as Dr. Madhu has already mentioned, like how to the duration of the treatment. Most of the time, it will be a lifelong treatment. So how to convince them to continue the treatment, and I don't know. But for the time being, they are happy. So whether they will continue the treatment, I'm not sure. But anyway, from the literature, it has been shown that DGCI approval has been obtained for this in the NASH, and we see some hope at the other end of the tunnel that it may have some finite role, but we don't know.
So my next question is to Dr. Raja Prasad. Yes, you mentioned that your practice is mostly surgical, but this is a general question about the objective of treatment. Would it be different based on the stage of disease? For example, is it palliative, curative support? How would you make that determination based on the stage and diagnosis?
Like Dr. Biju and Dr. Madhu has mentioned, it is very difficult to tell, how the progress of the disease is going to be with different patients. So considering a disease which has got a high chances of either it can convert into steatohepatosis or fibrosis or cirrhosis, but still not being sure about which of the patients will really benefit with the medications that we have, it's very difficult to convince a patient to tell them that they'll surely benefit with a particular drug or not. Like Dr. Biju has said, lifestyle modification, exercise, and diet may still be the main modality of treatment because that is still in the patient's hand with probably not too much of an expense or a long-term commitment towards using any particular drug. But like he said about the latest drugs which are coming for the treatment of NASH, in cases which are a little more advanced, who actually have a NASH disease, not a NAFLDs, and who are high risk to develop cirrhosis or fibrosis, pharmacological therapy may benefit in those patients. But other patients, I always feel there will be lots of patients who may not continue the treatment beyond a particular part of time because either because of the cost of the treatment or because they'll just not take it after a certain point of time.
Thank you so much, Dr. Raja Prasad. As I mentioned, we have been tracking with a lot of interest the development pipeline and the clinical trials for NASH across the world. And you would be very excited to know that this is actually the number of products in development, over 100 products in development across multiple stages of development. The point I wanted to touch upon was your thoughts about ongoing clinical trials in India for NASH. My question is to Dr. Madhu. What might be, in your opinion, the challenges for conducting clinical trials for NASH drugs in India?
I feel that the most difficult part in such conducting such trial would be getting a liver biopsy. Without doing a liver biopsy, you cannot be sure that the patient is actually benefiting or not. So just an improvement in ALT or AST doesn't mean anything unless you can prove that there is histological improvement. So getting a liver biopsy done is another costly procedure in India. So probably that would be the most limiting part, I feel.
Dr. Biju, can you comment on the availability of patients for enrollment in clinical trial?
Actually, from on my clinical practice, we practice in a private sector. So to get a patient involved in a clinical trial is very difficult because most of the time when we are explaining to the patients that this is an experimental drug, and very difficult for them to convince and include it in an experimental trial, especially in a patient with a private sector. They are paying for everything for the visit and also for the investigations, labs, follow-up, everything. And for them, as and to introduce them to quantify further imagings like CT, MRI, etc., they may have to pay. And also for this liver biopsy, so we are subjecting the patient for a trial, and we are doing a invasive procedure which may have potentially harmful hazards around. Even though the incidence is very less, we may have to explain to them also this sort of, and so very difficult for them to convince and put them into a trial, for which we have got a lot of other factors which are likely to modify the disease, like diet control, exercise, etc. We can tell them that this can also modify your disease, which they are also aware of those things. So very difficult for them to get into a trial for NASH, because most of the time at present they show that they know that they don't have any symptoms. So whether to convince them to get into a trial and to prevent a complications which they expect after 10 or 20 years, for to convince them is very difficult. And also to how to monitor the patients on trial, whether they are, because only the drugs cannot help. We have to other confounding variables like exercise, diet control, etc. also has to be go along with these drugs. So how to standardize these exercise, diet control, etc. We know that in India, from south versus north, south west, east versus west, etc. We know that the diet contents of the food, whether the glycemic index, fiber content, fat content, whether the vegetarian versus non-vegetarian, etc., vary from every part of India, every part of the states itself. So very difficult for them to have a standardized protocol for these sort of trials. Only drugs can have the trial, but there will be other the drugs to know that whether the drug is producing effect. As Dr. Madhu says, we require liver biopsy. Without liver biopsy, we can't go ahead with the trial in a very positive way.
Dr. Biju, that's a very important point. Dr. Raja Prasad, my question, a follow-up question to that was, the endpoints that are usually measured for the clinical trials in NASH, are they obtained during short-term follow-up, medium-term, or long-term follow-up?
Most of the drugs or trials which are given, I mean, you need a minimum of 8 months to 1 year of drug usage before you define or tell whether they're improving with the drugs or not. And like Dr. Biju and Dr. Madhu were saying, it is very difficult to tell, I mean, which of the patients, I mean, whether you're going to take a NASH who's got some more signs of fibrosis or who's into cirrhosis, which of them are you going to choose? And without a liver biopsy, it is very difficult to tell when to repeat a test or whether it's really necessary to do a test for them. And liver biopsy, like Dr. Biju has said, has got its own risks, like bleeding, and especially if they're cirrhotic and all, they can have eye bleeding if they're not monitored properly. And it has to be generally done in centers which have good experience in doing liver biopsies. So the limitations of doing the investigations to actually prove whether the drug is working is more important than the time gap. I mean, you need to give it for a long period of time, and you need to expect the patients to come back to your follow-up to get the test done again to confirm whether it's actually improving from the disease. So this is a big limitation when it comes, because the follow-up will be a very long follow-up. It's not a short. We can't assess a patient, reassess in 1 or 2 months for the patient. You have to at least give it for 8 months to 1 year before you reassess.
So, Dr. Prasad, are some patients lost to follow-up? Is that a limitation?
I'm not the best person to answer this because we don't undergo these trials, but just giving a perspective about the duration and the follow-up, because lots of other patients, when we ask for a follow-up, we have very few patients who actually come back, because based on the situation, they try to go and meet a doctor who is closer to them, and they rarely come back to the same doctor if they don't like what you're telling them.
Absolutely. Doctors, shifting gears a moment now, this is more about a general liver health and how, or rather what the expectations and experiences are in the recent period. For example, my first question is, what might be your expectations from a pharmaceutical company beyond providing drugs? So, for example, do you think the pharmaceutical company has a role in patient drug access programs, patient service programs, and awareness programs? Dr. Madhu, please.
I would suggest that pharma companies have got a big role. They can play a big role in bringing up this pandemic to public eye. So maybe they can use some smartphone apps or do some programs to increase the metabolic syndrome awareness. They can probably bring down the prices of these drugs which are being used for fatty liver. And maybe patient support program would be an ideal option for patients, because these patients need medicines for long periods of time, and these are very much costly also. Yeah.
Thank you, Dr. Madhu. Dr. Biju, your thoughts on the role a pharmaceutical company might play beyond drugs itself?
Yes, definitely. Pharma company has got a big role to play. As Dr. Madhu has already mentioned and in detail regarding the patient support program and all. And also, they can advertise and not advertise, give information through the this internet, through telephones and other social medias. They can give information regarding this pandemic and what are the preventive measures and how long to take the treatment, and also to improve the patient awareness and patients sticking on to the treatment program. They have to closely monitor the patients with electronic devices like smart watches and pedometer, etc., and how their nutritional calorie, how the calorie they have, which they are taking, also has to be periodically monitored like that. And actually, and also in the drugs, also the drugs which are the cost of the drug also has to be come down, and also the drug which is likely to reduce the incidence of cirrhosis and reduce the incidence of HCC over the long term follow-up. This drug has to evolve over the years. Then we still have the hope of treating the Nash. And also they have to be, patient has to be educated regarding the nutritive value of each food, and also they must be educated that the people depending on this thing, artificial food or food supplements, they have to be very careful that the people who are using it has to read what are the contents in the food supplement which they are taking. And also the government system has to be very strong enough to check whether this whatever written in the menu or is actually tallying with the real content. I'm not sure whether this is tallying in our country, whether the supplements which is written in the menu, whether it is tallying with the actual content. Also has to be strictly monitored by the authority and the machineries. And the pharma company also has to see that these things are properly maintained in the proper way in our country.
Absolutely. Dr. Prasad, your thoughts, please, and your expectations from pharma companies beyond medicines?
Yes, the first and foremost, I mean, like any of us think, is an unbiased patient education towards the disease. So an unbiased, I mentioned, is when they don't relate any drug to the improvement of the patient's health. At the same time, giving a general, fair educational information to the patient about how to take care of his disease, like lifestyle, exercise, and what are the non-pharmacological things which they can take care of before they actually come to a pharmacological treatment. Because most of the times we see a pharmacological educational process which always mentions about their products and then about how it is going to benefit them. So if you have a good information about the disease and how the patient can take care of it by himself without a need for a pharmacology, rather than unbiased educational brochures or an educational things either in the hospitals, that's one of the things which will be very good, because whenever patients see an unbiased opinion, they tend to take it more than when they see a biased opinion or a biased advice regarding some disease. Second thing is, I've seen in a few of my practices when patients require long-term medication, we directly attach them to the company itself so that the company provides the drugs to them at the best price instead of they going through a pharmacy. So sometimes in chronic pancreatitis and in patients who for inflammatory bowel disease where they require long-term drugs, we generally attach them to a pharma company guy who actually gives them at the best price so that the patient will have more compliance in taking the medication. I think if that can be available to them and a good education, I think that is what a pharma company with its resources can help be of a good help to the patients.
Absolutely right, Dr. Prasad. Especially given the reach of the pharmaceutical company on the ground, they will be able to support a lot of information and access initiatives. I was thinking about a couple of examples I've seen in the oncology practice in India. Many leading pharmaceutical companies have subsidized or completely supported biomarker or diagnostic testing for the patient. For example, uh, before physicians consider treatments like Herceptin in breast cancer, the pharmaceutical company completely subsidizes or supports HER2 testing. Or in the case of non-Hodgkin's lymphoma, before giving any anti-CD20 drugs, the pharmaceutical company completely does it for free, the anti-CD20 testing. So, to that point, do you think that there are any biomarkers or testing that a pharmaceutical company should be more actively promoting from an awareness and access perspective? Dr. Madhu, please.
I don't think it will be financially viable. I'm not very sure about it. I think patient awareness regarding his metabolic syndrome status would be more rewarding
More
on
rewarding.
the
Okay.
pharma side. If the patient is aware that he has got fatty liver and he is high risk for a fatty hepatitis, then probably he'll come to the doctor asking for test and treatment. I don't think giving a panel test like FIB4 or FibroScan or something, I personally don't feel that it is going to benefit.
Absolutely.
Yeah.
Dr. Biju, your thoughts on this point, please?
No, yeah. When considering a biomarker, the biomarker should be helpful in us in the diagnosing the disease, in prognosticating the disease, in severity of the disease, and also in assessing us when to stop the treatment. As far as our Nash or non-alcoholic steatohepatitis, we don't have any significant biomarkers till now. Like as you rightly mentioned in the oncology practice, like that. So I don't know whether the biomarkers can do something ahead and at this point of time regarding this issue. What is most required is the patient education and patient motivation, and also the available drug at that most subsidized rates. I think that will be the way to go ahead.
Absolutely. Doctors, just a quick time check. We're almost coming to the end of the discussion, and I wanted to come to perhaps what is the most important point that we need to discuss today. That is the impact of the COVID-19 pandemic on the disease presentation and diagnosis, and the way it is managed given the severe constraints that the healthcare system is under. Dr. Raja Prasad, can I start with you, please? How has the pandemic affected diagnosis, treatment, and follow-up of liver diseases in general and NASH in particular?
So I couldn't hear you, Rebu.
Dr. Prasad, my question was your thoughts on how the COVID-19 pandemic has affected the diagnosis and presentation of liver diseases, and how the healthcare system, under already severe constraints, is able to manage that liver diseases now.
Okay, I mean, the present situation of COVID-19, there are two ways about it. One is it's very difficult for the patients to come to a hospital, I mean, for a fatty liver or a NASH disease, because it's not an emergency. But looking at it the other way, I mean, patients who already have this disease, probably if they're staying at home or working from home, they have much more time to take care of their health, like either lifestyle or the dietary modifications and exercise. Because
I think we might have lost Dr. Prasad to a poor connection. Dr. Madhu, can I ask you your thoughts on how the COVID-19 pandemic has affected the diagnosis and treatment of liver disease in general?
Patients usually solicit advice for fatty liver usually after executive checkups when they find that the left is abnormal. So we don't actually probably get patients like this coming to hospital nowadays. So it is more of a problem with reduced follow-up of patients whom we already know have fatty liver. So these patients are not following it properly because of fear of coming to hospital and getting infection with COVID. And another concern of many of these patients is where they are always concerned whether they can take the vaccine when they have fatty liver or cirrhosis. So all these kinds of patients are also only coming to hospital nowadays. So fatty liver, routine fatty liver cases are less, I feel, getting picked up.
Thank you, Dr. Madhu. Dr. Prasad, we lost you briefly there due to a poor connection. You were saying, Doctor, about the challenges in presentation and diagnosis?
Yes, actually, like Dr. Madhu was saying, I mean, NASH and NAFLD may not be emergencies for patients to come to the hospital to seek treatment for the same. But this COVID situation can be an advantage for patients who've already been diagnosed and who've been given advice about a lifestyle modification. Because since most of them are staying at home, working from home, or are relatively free as compared to earlier, they can take this time to take care of the lifestyle modification, diet, and exercise. So probably if, I mean, they take care of their health, I mean, in terms of exercise and lifestyle modification, it will be good for them, I mean, other than using just the medication. I mean, they have to look at the brighter side of the lockdown or the staying at home.
But they're staying at home and eating more nowadays. I feel.
So that was my question, Dr. Madhu. In fact, richer diet, more sedentary lifestyle, and lesser interaction with doctors. So,
Exactly.
do you think, therefore, there's a greater role for telemedicine to play in this time, Dr. Biju?
Yes, actually, the telemedicine has helped in this COVID area, especially not for this fatty liver patients. Actually, especially the fatty liver, the incidence might be increased. Especially what we are seeing is now during the last 12 to 13 months, majority of the students in the age of around 15 to 16 to 20, they have gained up to in the weight of up to the tune of around 7 kg to 12, 15 like that. So they have definitely accumulated fat inside their body. So the incidence of this is increasing because of the pandemic, I feel so. Especially in the younger age group, the incidence of this this fatty liver is increasing. Whether they have got steatosis or steatohepatitis, which nobody is bothered because they are not checked, and nobody is not coming for this asymptomatic illness nowadays to the hospital. So the telemedicine has helped not for this fatty liver, but for patients with the chronic liver disease. They don't have any active issues like fever or altered sensorium. They can have use the facility of the telemedicine, and they can modify their medications, and the fear of coming to the hospital is reduced. Especially in the patients with the chronic liver disease, patients with the chronic IBD, etc. They can utilize these facilities. But chronic liver disease, we have to always use this facility with a pinch of salt, because most of the time we cannot assess the patients. Assessing the patients clinically is very important as far as the chronic liver disease is concerned. So only for patients with the stable chronic liver disease, especially steatosis, steatohepatitis, or child A cirrhosis, child B cirrhosis, and child C cirrhosis, they cannot rely most on the this telemedicine system unless they are in a very stable situations. Telemedicine has helped a lot, but it has limitations.
Excellent, Dr. Vijay. Thank you so much. As we come to the close of the session, I would request each one of you to say a few words as messages to the general audience and your peers who might be listening. Dr. Prasad, may I request you to go first? General advice on liver disease in general and NASH in particular to the audience for this meeting.
Yes, I mean, good lifestyle modification, diet, exercise, and can't say absolutely no alcohol because that's quite difficult for most of them. But moderation to the alcohol as much as possible is the best way to go ahead with the treatment.
Thank you so much, Dr. Prasad. Dr. Madhu, your message to the audience?
My advice would be to follow up regularly, even if you are scared of coming to hospital. If you are cirrhotic, you should follow up regularly. Your lifestyle should be so that you don't put on weight sitting at home and eating, and do regular exercise and take your medicines properly. I think probably more of a healthy lifestyle is more important during this lockdown time.
Thank you so much, Dr. Madhu. Dr. Biju, closing thoughts?
Yeah, during this COVID season, we have to practice all precaution measures like sanitary hand sanitization, mask, and safe distance. And along with that, we have to take all required medical attention in the proper time itself. Don't be afraid of the pandemic situation. We have to seek medical attention in the proper way, in the proper time, with the proper duration. And as far as the NASH is concerned, good lifestyle as much as possible, reduce the alcohol, exercise, and restrict the calorie intake, and as much as possible vaccinate against hepatitis B and hepatitis A, and also strict control of all reversible factors like diabetes, dyslipidemia, hypothyroidism, and try to reduce the intake of the drugs which are, whether it is modern medicine or over-the-counter medications, try to reduce the intake of medications, and the medications has to be the proper duration under the strict prescription of a medical practitioner only. So try to reduce the intake of drugs also has to be taken into consideration for healthy liver.
Excellent. Thank you so much, Dr. Biju. Before I close, I would like to thank the organizer, Voice of Healthcare, and the team for setting up this very informative and engaging conversation. I'm sure the audience has benefited from the expertise from each and every one of you. I wish you and your families safety and health. Thank you so much for joining. Thank you. Have a good evening.
Thank you. Thank you.